having a baby, you'll want to hear this next segment. The Department of Health and Human Services is trying to determine whether treatment for infertility is an essential health benefit that should be included under the new health care reform law. Joining us for a fair and balanced debate on this is Risa A. Levine, a member of Resolve, the National Infertility Association. She's also struggled with infertility for years. And Michael C. Barnes, attorney and policy advisor. And I'm also a new board member of Resolve, so I've been eagerly anticipating this conversation. Welcome to both of you.
Thank you.
Michael,
Thanks, Allison.
I want to start with you. Isn't the ability to have children, to procreate, considered essential?
Well, that's not the question here, really, because we've got to look at how to be able to provide adequate health care to people in a way that's affordable so that we can provide any health care to people. So the decisions on what benefits are going to be included really need to be decided by who's going to be paying for the insurance. And the government is not going to be paying for those people who are going through their employers or choosing individually. So the government shouldn't be making that decision about what benefits are provided and therefore what the cost will likely be, higher, that is, than if those benefits and other very valuable benefits were excluded.
Yeah, sure, but I mean, when you say other valuable benefits, I know women whose contact lenses are covered, allergy shots are covered, yet not the treatment to have them have a baby that they desperately want?
Well, obviously they have luxury health plans, and it would make sense for insurance companies to add benefits to their plans for people who have those benefits, like the contact lenses included. But for individuals who want more basic treatment that is more affordable, for example, that would just provide catastrophic coverage, and want a lower price plan, it makes better sense to exclude those benefits for the purpose of pricing.
Risa, what's your response to that? Obviously, it's all about price, yet I know that you think this is a vital need.
Well, of course it is, Allison. Having children is fundamental to the human condition. It's a choice that we make that separates us from the animals. The desire to have children is clearly essential. It's a life-sustaining action. But more importantly, the flaw in what Michael's argument is that numerous studies have shown that including infertility coverage in health care packages actually lowers the overall cost of health care. There are risks associated with taking actions. When people don't have coverage, they make bad medical choices. For example, a woman might choose to do an intrauterine insemination which is commonly referred to as artificial insemination, instead of an IVF, which is a less likely to be covered, more expensive procedure. But the incidence of multiples, high-order multiples, is much higher with intrauterine insemination than it is with IVF, where you carefully monitor how many embryos are put back into the body. And therefore, the cost of multiples, women being on bed rest for extended periods of time, premature deliveries, long NICU stays, birth defects over time that may be associated with high-order multiples is far more extensive. There are several studies that show that in New Jersey and Massachusetts, which have the premier infertility coverage in the country, that costs went down after infertility treatment was mandated.
And we should mention that, sorry, Risa, to interrupt, but we should mention that at the moment, the way it works is that 15 states, basically infertility coverage is decided state by state, and 15 states do have some level of coverage, though it's often inadequate because for IVF, Risa, as you were referring to, it's $12,000 a pop, and one IVF treatment rarely gets the job done. Michael, very quickly, do you consider fertility and having a child a vital medical need?
I don't think it is a vital insurance benefit. And there are 2 points that I want to make really quickly. The first is that among those 15 states, neither of them, and none of them, is likely a model for quality health care and fiscal responsibility. There's no model of that nature in the nation. And we also, in this debate, have been ignoring the fact that the biggest question that has been plaguing domestic politics over the past 2 years is how to provide quality health care at an affordable cost and to align the risks, the incentives, and the costs for consumers of health care. And so saying that whatever is currently working is the solution is really ignoring that fact.
All right, we'll continue this debate on my blog. Obviously, it's a very hot topic. Risa Levine, Michael Barnes, thank you so much for coming in and talking about just how emotional this can be for people. We appreciate it. Meanwhile, the